Welcome to this Government Today debate. My name is Christine Bond. I'm Professor of Primary Care at the University of Aberdeen. And it's my pleasure to chair this debate today. And what we're going to be discussing is whether prescribing generically actually does save money. Generic drugs are unbranded preparations known by their approved name that contain the same quantity of active ingredient as the original proprietary medicine. Generic drugs are approved for use and they have the same clinical effectiveness as the original brand. It's generally recognised that generically prescribing is a good thing, it's said to be cheaper, and it's said to be a marker of quality. And it's generally encouraged. But recently, Category C branded generic medicines have been introduced and have changed the landscape. So what we want to think about today is does generic prescribing still really save money? At a time when there are increasing demands on the NHS and a limited budget, it's a very pertinent question to be asking. To help us consider these issues, I've got a panel of experts to join me. On my right, I've got Dr. Martin Duerden. He's a GP and Assistant Medical Director of Betsy Cadwallader University Health Board. He has previously worked for the National Prescribing Centre and Department of Medicines Management at Keele University, and he's a clinical advisor on prescribing and evidence-based medicine for the RCGP and is a member of one of the NICE Technology Appraisal Committees. On my immediate left, I've got Shailen Rao, a pharmacist with many years of NHS experience as a lead advisor. However, in 2007 he left the NHS to form Soar Beyond and now provides pharmaceutical advice to GP practices and to CCGs. The aim of Soar Beyond is to help the NHS and the industry maximise its return on investment in medicines. And on my far left I have Ash Soni. He's currently President of the Royal Pharmaceutical Society. He's also a community pharmacist and member of the English Pharmacy Board. Ash qualified in the 1980s and was one of the early pharmacists to work actually in a GP practice, advising them on their formularies and on their best practice in prescribing. He is currently the clinical network lead for Lambeth CCG. So that is my panel of experts. And I'm going to turn now to my first question to pose to the panel, which was really to just consider that question. The first question, in its broadest sense, does prescribing generically still save money? And is it an issue of quality of prescribing, or is it a financial one? Dr. Duerden, perhaps you'd like to answer first.
I don't have any doubts that continuing to prescribe generically does save money. I also think it is a quality issue. I think it's something that should be encouraged, and I think it's almost become a cultural issue within the NHS, and our doctors are trained to prescribe generically, hospitals use generic names, we communicate in generic names. It's a good way of maintaining a continuity of care for patients. And also when we use a generic name, it helps to convey something of the science of the drug. I think we have saved an enormous amount of money in the NHS by using generic drugs. I don't think there's any doubt about that. However, I think we need to be careful about being overzealous. And I think in the past there have been issues where we've pursued the goal of generic prescribing, the concept of generic prescribing beyond the point at which it's been effective and may have been detrimental. That pursuit may have been detrimental to patient care. So there are instances when you should not prescribe generically, and I think we need to try to encourage that and to hold that. I think recently, and I've been as much involved in this as anybody, within a health board or within a CCG or whatever other organisation you work in, we are very, very cash strapped, and with Category M savings and now Category C issues, I personally don't see any harm in chasing, if you like, a cost effectiveness by changing some of the ways that we prescribe, because I don't think we really have much choice. We have to pursue some of those savings.
Okay, thank you very much. So financially driven prescribing is clearly important. Maybe I could now turn to you, Shailen.
Yeah, I think just picking up Martin's theme, it's definitely, I think for me it's always been clear, and we need to be very honest with ourselves, that generic prescribing has largely been a financial issue. Yes, there are some quality issues within that, and I think patients definitely need access to branded medicines, particularly when there are bioavailability differences. There's a quality element, but those have been the icing on the cake, if you like, and largely it's been a generic sort of financial issue. And over the last decade, maybe a bit more, we've made massive strides. I remember working in the NHS 10, 12 years ago when generic prescribing rates in my area would have been less than 50%. We're now well up into the 60s, 70s, 80s is what I see. So I think largely it's a case of job done on that front. Every rule has an exception, and I think there are exceptions to the generic prescribing, both on a quality front, as Martin's highlighted, and I've just mentioned the bioavailability differences, patient confidence sometimes, particularly for specific illnesses, mental health would be one. But there are also financial exceptions to that rule, and Category C is a really interesting debate, certainly more to it than meets the eye, and I think we'll probably delve into that later.
Yes, I think we'll come back to that. Just looking
Sure.
generally now, Ash, what is your take on this?
And there's no doubt it's been financially driven, and it makes sense because actually, to a great extent, it has been about how do you make the NHS most cost effective, and the use of generics is a mechanism that helps that to happen. I would follow the 80-20 rule. I think that there is about 80% that you probably can prescribe generically. There's about 20% you probably can't, because there are a range of drugs that it is inappropriate to do it because of safety and quality issues, particularly where we've got biosimilars or we've got drugs which are slow release, and there are specific drugs for epilepsy and particular conditions where I think it's really important that we are really clear that slight changes in the way that the drug operates may be significant in the outcomes for that patient. And we also need to recognise that for particular patients there are always going to be specific issues which occur around the way that a drug is constructed within the formulary, within its formula, even though it is similar. So I think in the majority of cases, absolutely, we should see generics as being the value for money proposition, but recognising the extent where there are products which it is unsafe to do that. And actually what should happen is we should be working on the principle that quality and safety comes first, and when you know they are equivalent, then you take the most cost-effective option. So I think historically that's what doctors have done. That's the algorithm they've worked along, and actually that is the way it's been done. It's been very effective in that respect.
Okay, so I think you're all agreed that in principle generic prescribing for the majority of patients is the right decision, and it will save money, but you've also hinted at the fact that maybe there's times when it's not such a good idea. So maybe we could come back to that and think about the various categories where it might be preferable to use an alternative to the generic. Maybe I could turn to you, Shailen, first.
Yeah, so I mean, I think we've covered the quality clinical areas around bioavailability differences. So I think the interesting thing in the current day is looking at the exception to the rule on the financial basis, and for me that's Category C particularly. So we've got this slightly anomalous kind of scenario within the drug tariff where prescribing by brand now is the exception to the rule, is actually cheaper in certain cases, because the way Category C works, the benchmark is often against the market leader, which is usually the more expensive agent in that category. So whatever, even prescribing generically, on the face of it, looking at just the prescribing budget, you potentially as a CCG or a health commissioner will end up spending more because you'll be charged for the higher rate. So to prescribers, I think it's a hard one to get your head around because it's sort of counterintuitive in that respect. So on a simple level, it's a bit of a no-brainer. You prescribe something that can be half the price when it's written by brand, and it's the same agent. Often the patient will be getting exactly the same box in their hand as well. So there is a clear saving to be made. What we have to be also mindful of is the less obvious thing beneath the surface in terms of what impact that has in the pharmacy funding mechanism. And there's this big debate, I think, about whether some of it get, or all of it get paid back to pharmacy in a different route, which is where the debate really does get interesting. But I think from a CCG budget management point of view, it's a bit of a no-brainer from a saving point of view that you prescribe that group of drugs by brand, and you can make significant savings. And there is a quality issue that the patient then is getting the same brand every month.
Yeah,
yes, I think Dr. Duerden, you want to come in on this?
Well, there are lots of different issues there, aren't they? And it's quite a complex discussion in many respects. But the issue about category M, I think, is crucial in that if we do encourage prescribers to use branded products because they can save money, we're mixing a message. We're saying it's really good to prescribe generically. As much as possible, we'd like you to prescribe generically. There are some instances where you shouldn't prescribe generically, such as modified release, such as the bioavailability issues with epilepsy drugs and with lithium, and also with biosimilar type drugs and those kinds of things. But then on the other hand, we're saying for this particular instance, we're going to chase the profit and we're going to step aside from these principles. And it is quite difficult with GPs, and they feel that we're selling ourselves, that we're not doing the right thing, and we have debates about that. I think generally they accept that there is a necessity to make what we can of the system, and in some instances we have to step aside from our principles. I'm not so concerned about the category C issues because generally it relates to modified release products, and I think one of the messages we give is that if you prescribe modified release products, generally you should prescribe by brand. So I don't think it causes too much of a problem in that circumstance.
I mean, you make a very good point there, I think, which again I think is all about picking your battles and working at organisational level, which is, and that is the issue. You are going against the grain, and somebody in my kind of role for years I've been drumming home this message to prescribers, prescribe generically, and suddenly I've come completely a full circle, it seems, on the face of it. But I think the principle thing is important. What was the principle we were really wedded to? It was to save money. It was a cost-effective strike. So I don't think this is a departure from that principle. The issue here is more the implementation and the confusion it creates. So I think working at organisational level, if medicine's management teams sort of get the message out that this is an exception to the rule, it remains an exception, but for this carefully selected basket of interventions, we, just those, we want to be prescribing by brand, and we will provide you the support and the communication that you don't have to sit there every time you prescribe and think, should I be prescribing by brand? We also have now more sophisticated tools on, in terms of IT, things like script switch, that enable that to happen more smoothly. And I think if you think of it from a finance point of view, the investment you have to make in running that team and the time you take to make that happen effectively can be well rewarded with the return you get back. But I totally agree, you have to have a carefully selected basket.
So you seem to be endorsing it on the basis of finance. You're querying whether it causes confusion. What about the community pharmacist's perspective?
Well, it's interesting because, of course, Category M and Category C have specific relationships with the community pharmacy contract.
Yes.
And there is an element of Category M which is about the profitability for pharmacy and is utilised as a mechanism to make that happen. Because one of the things pharmacy has been very good at throughout this period is that as we've prescribed generics, as doctors have prescribed generics, we've been driving costs out the system because we're buying more and more competitively, and that has been utilised as a real benefit for the NHS. And the National Audit Office have produced data to show the amounts that pharmacy has saved through that, in excess of £2 billion. So the numbers are enormous. And I suppose my challenge becomes that if you take the money out through using more Category C, you'll have to replenish it back into the contract in some shape or form. So the cost comes back to the system in some way. There is a challenge in the sense that at the moment for the breakdown of the system is such that CCGs pick up drug costs. The rest of it for pharmacy is picked up nationally. It comes out of NHS England. So there can be there's some perverse incentives in that there can be some savings for the CCG, which then get passed back to NHS England, which has to make up the shortfall because there is a global sum attached. The thing that worries me about Category C more than anything else is that where it's modified release, yes, and we follow BNF guidelines which talk about using specific branded product because it's appropriate to use that for the patient. However, when it becomes slow release, modified release in some shape or form, there is a real risk because what you get is the opportunity to get a product which may be cheaper, but how long will it be cheaper for? Because what tends to happen is that they will adjust category M to reflect that, because actually there is an element, as I say, which has to go back into the system in the way that the contract is funded. So a really good example of that was that we went through a phase, and a number of CCGs went through it, where we've always prescribed salbutamol. And there are a few patients who you prescribe Ventolin because there are specific issues around it. Then there was a stage where, for whatever reason, category M had got to a point where the price of salbutamol was significantly higher than the price of Ventolin. So what happened was, CCGs wrote to all the GPs and said, stop prescribing salbutamol, prescribe Ventolin. So what happened? The drug tariff responded effectively, because it suddenly saw the risk to the CAT-M funding model, and effectively the price of salbutamol was dropped as a generic, and the money was put into other products. But the consequence then became that then a week later, a letter goes out to GP said, really sorry, wrong idea, don't prescribe Ventolin, go back to salbutamol. Now that makes an even more mixed message, becomes even more complex for general practice to be able to sustain that.
Can I jump in there?
Please do.
I think that is one of the issues with the system of drug reimbursement. I don't think you can really criticise commissioners, health boards, CCGs for pursuing that, because it makes sense to them, and whatever short-term gain is beneficial for the health economy. The real issue there is the way that Category M has been set up, and presumably Category C has similar issues, that it is a fluctuating basket. And what seems to be a good idea in terms of prescribing one quarter may be quite different another quarter. You mustn't forget that there's a patient in all of this.
Absolutely,
well.
absolutely.
And I think we do, that issue about generic prescribing, I think, is really important in terms of how patients understand what they're getting.
Yeah.
And I often say to patients, if they're buying themselves pharmacy sales medicines or things like paracetamol, or ibuprofen maybe, make sure you get the cheapest version of this particular product, and we're prescribing on that basis. So we're confusing patients by suddenly shoving a brand at them.
Can I just ask, as a GP, do you get patients coming back to you querying the fact that they've got something which appears different, or are they now generally accepting the idea?
It's something I was going to say. Surprisingly, I probably get more patients coming back to me with a generic drug saying, what's going on here, than I do with the branded products that we're prescribing, maybe because of Category M or Category C, because then they're getting continuity generally. Now what happens with generic products is every month that they go and get their prescription, every few months they go and get their prescription, they get a different packet. And the packets might have a calendar pack one month, and there may not be a calendar pack the next month, and the boxes look very different, the pills generally look the same, and they get really quite confused. Am I getting the same drug? So there are similar issues with generic prescribing, and to a certain extent I think patients have just got used to that and just adapt to it. I think the issue about, I'm going down a little tangent here, but the issue about calendar packs or not calendar packs is fundamental to encouraging patients to be adherent to medicines, and I do think there ought to be some standardisation of the way that these things are presented.
Okay, that
if
is
I can
slightly
come back
different.
to Ash's couple of points,
Could
really
I
important
just-
points to clarify, because the point about Category M and salbutamol, so I said earlier, pick the battles carefully, and for me, very clearly, anything outside of Category M I wouldn't consider prescribing by brand, very exceptionally perhaps, because the prices do fluctuate. Category C is a very different kettle of fish. If you look at the prices, they tend to stay the same because it's benchmarked against the original branded product. So to take an example, Voltrol, which has been off patent almost as long as I've been practicing, has that price for diclofenac modified release is still benchmarked against Voltrol as far as I'm concerned. So those prices don't change that much. So when I look at it and say, what is the likelihood of prices fluctuating in this category, next to zero,
In the Category C
in
category.
Category C. So that's why I separate the two. Everything that's branded outside of Category C I would look at differently, and again think very carefully because the prices do fluctuate. Coming back to the earlier point, though, very important point, and this is really the whole nub of the argument with Category C, this concept of you make savings in Category C and do you end up paying it all back through Category M? Well, if you look at the way that calculation is done, to be able to do that, you've got to detect accurately the amount you've saved in order for it to be paid back. And if you look at how that's done, that leaves a lot of questions unanswered in my mind and creates uncertainty as to that payment going back, which is, the mechanism is the margin survey. Essentially in a year, there are, I think, 120 pharmacies that are surveyed with their invoices, and there's only a list of 300 products in total. I mean, it's about 120 branded, 120 generic, and about 40 special, something of that order. So I'm left questioning whether these specific selected products you prescribe are actually in that list. Probably not. I mean, and by its nature, I assume that can't be shared because there would be gaming. So actually, the likelihood of that saving being detected at category C in order to be able to put it back into category M is, again, in my mind, very low. So we are probably not, even though the mechanisms is set up that way, it's not sensitive enough, I think, to pick some of these off. So you're probably not paying it back. There is actually a separate argument about whether category C needs to be there to maintain viability of community pharmacy. And for me, that's sort of out of scope of my remit. I definitely don't want to see community pharmacies destabilised. But I think there are two separate issues. Does it all get paid back? I think probably not. Could it destabilise pharmacy? Possibly, and that is a concern that we have to be careful about.
Ash, can you comment on that particularly?
Yeah, and I think absolutely yes, it probably isn't sensitive enough, but actually for particularly when you get this variability across CCGs or across organisations, is that it is a basket and it's based on averaging. So what it's designed to do is to say, as with any averaging system, there will be winners and there will be losers, and that's accepted. That's part of the way it works. But if you happen to be in an area which is very positive about using category C compared to another area which doesn't, or the rest of the country in some ways doesn't, the pharmacists in that area are much more likely to be destabilised because there isn't then the return that's coming back for that group, because there isn't the sensitivity to show that they're losing. And so there is some risk in that. And generally what I would tend to say is that overall it probably isn't a huge problem, but it's more about the impact on healthcare on people. Having said that, I think there is some real issues about the way the contractual framework is now structured. And when it was put together originally in 2005, there was a lot less clarity about the numbers that were in the whole system. And over the course of time, that's been done more and more, and actually the numbers that are coming out of it are getting tighter and tighter. And therefore, some of the flexibility that pharmacy used to have, in the sense of, I don't need to worry because there's this little bit which is going to cost me in whatever shape or form, I'll make back because the overall basket gives me sufficient capacity to be able to make that happen. As that's got tighter, it's become more difficult to do that. And as a result, probably we're at a point where we need to relook at some of the things which sit within the contractual framework and the way that discounts and pricing is applied in the current market, and going forward how that happens. Because the system, as with anything, will change over a period of time. You know, if you go back to as you said, 15 years ago, the level of generic prescribing was quite low. It's risen, it's climbed to a significant amount. In the same time, that's been utilised to be able to get more money out of the system, because it's been used as a mechanism for pharmacies to purchase more and more efficiently to drive cost out of the system. And that's reflected in the reason that you have category M, is because you need the profitability to encourage pharmacy to go and chase a bit more in the margin. Because if you take that away, then why should I bother? And if the price becomes £100 for a product, hey, it's not my problem.
And I think that's important to recognise there are two different arguments. But I think that the unhelpful element of this is to say, well, it gets, there's no point you guys making any sense because it only gets paid back. I think that's different to, needing to maintain viability of pharmacies.
But you can't ignore the two sides of the argument. So because
no, it's just being clear about which one you're acting on, because a lot of people are saying, I'm not doing this because it only gets paid back.
Yeah.
Well, actually, that might not be the case. In my opinion, it probably
if you want
isn't.
a policy decision, say from your CCG, you have to consider both those arguments.
And it becomes more complicated, certainly in England, where NHS England are responsible for commissioning community pharmacy, not CCGs. So that adds another degree of complexity. CCGs say, well, that's not my worry. Yes, I want to see pharmacy viable, but that's somebody else's remit, not mine.
Martin, you were going to
Well, I was going to say, actually, at the ground level, really, I don't think we get into into that debate in any great detail, simply because what we're trying to do is working with the drug budget that we have, and so we're trying to keep it as lean as we can possibly keep it, and therefore that kind of debate about whether this is the appropriate thing to do in terms of whether we're making sure that community pharmacy is receiving the monies it's supposed to receive is really somewhat irrelevant to us.
And I think there is a third way, and maybe we'll come to it, is that, you know, I think I would be safe in saying none of us around this panel here started doing what we're doing to save money. That sort of came in along the way as a must do. And if we could, I think there's a greater opportunity here to say, if there is an opportunity that we can make efficiency gains, how about ploughing that back into working with pharmacists and redirecting that and using that small bit of fund. It's not going to be a massive amount we save, but it's a meaningful amount that we could do something different on the medicines optimization agenda, engaging pharmacy and to use the same resource. You know, that might be a good business case that I think CCGs might buy into, and, you know, local authorities, pharmacies.
I would say we do buy into that. You know, that this idea of developing the community pharmacy workforce and helping us work together with patients is fundamental, and I think that if we can provide those types of opportunities, that's excellent.
The other
Ash,
thing,
please,
the
yes,
other thing that
what
strikes me though that we
that.
need to bear in mind with category C is that, and it's interesting because of course you talked about Voltrol, and it's long for me, I suspect, if not longer. But actually one of the things that strikes me is that, of course, although it's benchmark priced, what's happened is that over the course of time, for the companies involved to a great extent, what they've done is they've scaled their manufacturing to just in time, to be looking at what is the current market, what is the demand, therefore what are we making. There isn't a huge amount of spare capacity in there at the moment. So if you suddenly switch from a generic to a Cat C brand, the risk becomes that suddenly you put enormous pressure on the system and the system can't respond quickly enough. And then suddenly actually you create the reverse problem about patients not being able to get the drug, because of course I've now, as a pharmacist, I'm now obliged to use that particular product, now can't get it, so now I have to get back to the GP and say, really sorry, this isn't available.
Well, when that happens, it discredits the whole process.
Exactly.
We've had examples where the supply just hasn't kept up with these changes that we've made.
And that's one of the things we have to be really careful about. So actually making sure that as part of this, as you say, it is a value, but recognising the fact that there has to be discussion, probably with industry, to be thinking about exactly
with all
this
stakeholders. And I think that for me is on the list of priorities, criteria, above price. I'd rather say 40% than 50%, or 50 than 60, knowing that when picking a product that is, you know, from a reputable company, the supply is going to be maintained. And there's a lot you can do at organisation level. I don't think it should be
and
left.
The price is going to be stable as well. That's
and I think, again, that's another criteria that I think there are companies out there that will give you that guarantee and a sense of a longevity. You know, you're doing this, and I've always said to prescribers, when we make this sort of change, we're going to do it once. And you know, you have my word that we're not going to come back and do it again. Because if you look at it as an area under the graph kind of scenario with 4 or 5 changes, even salbutamol save hundreds of thousands, millions in some areas over 2 or 3 years. It takes a long time to not, you know, if you ignore that saving, to be able to make up for what you've lost. So I think the key thing I've found works is you make a small number of changes and you have I guess a bond of honour with your prescribers, that you're not going to keep chasing the market, and I think people tend to buy that, and you get a significant return from doing that without creating too much confusion.
Ash, what about the patient's perspective as a pharmacist?
And two things that strike me. One was the thing about patients coming back because they're confused about the product they've got, the pack's changed, I don't know what it is, I don't recognise it. And actually, in some cases, even the pills do change in colour, or because there's particular brands which have established this is my colour and you can't use exactly the same, and things like that. And that can be a problem, and it'd be interesting to do some, I'm sure there must be research which shows whether there's been hospitalisation as a consequence of patients not taking those medicines, so they're not sure and they've lost confidence in the medicine. And it'd be really interesting to be able to look and see what we've got around that, and if we haven't, that we should be able to do some research around that to be able to identify how much of a problem that is. Because again, then you get to, it becomes an even more interesting discussion, is that actually, do you continue to drive price? Because there may be a value not just in cheaper branded generics, but actually in brands generally, because if you get consistency of product and therefore you get less hospitalisation, your cost to the system becomes lower because you've done something in a different way. And I think we need to think about that piece of this argument as well. One of the things I'd say, interestingly, from a personal point of view as a community pharmacist, is that as I said, there was the history has always been about chasing the money down and getting more value out of the system. But because of where we've got to, the amount of there is available, I don't do it anymore. So we just have an agreement now with one supplier, effectively, that we use their products for everything we supply. So even as a generic, I only use one brand of generic. So that people come in consistently and they will always get it, unless there's an availability problem. But of course, if there's an availability problem, I can deal with it because it's still written generically, so I can turn around to the patient and say, I'm really sorry, this time, normally we know we give you this, but this time we can't because there's a supply problem. We're using this, but it's exactly the same. So actually you deal with that issue because it creates the confidence that you need to be able to do it. So actually, whether that's as much of an issue today as it has been historically is interesting in terms of the variability of product that people use. And
anecdote tells me that it is a problem.
Yeah.
And I mean, obviously there are some pharmacies that do have a sustained supply of a particular set of products. I'm not in a position to direct patients, but I recognise that there are some people that are getting that kind of continuity, and there are others that aren't.
I mean, I just wonder if there's any way pharmacists and GPs at local level could work together with agreements to try and reduce some of these disadvantages. Do you have any examples of local collaboration?
We do have really good relations with our community pharmacy service in North Wales, and I think with the other thing that we have, which I suspect we're lucky, is we have a very good system of practice pharmacists as well, which I think a lot of the CCGs have struggled to maintain, which helps to maintain that kind of dialogue. But even I work in a rural practice in North Wales, or on the edge of a town, let's say, but heading into the countryside, and we have 16 pharmacies that we deal with. So for repeat prescriptions, it's very difficult to get a relation with one particular main pharmacist, and that's part of the dilemma that we have. And I suspect it must be the same for a lot of other practices.
I'm based in London, so you can imagine how many pharmacies there are around the practices I do. But actually, interestingly, you do tend to get a consistency of patient, whichever pharmacy they happen to use, and actually it is the patient that is at the centre of this, and actually being able to have that conversation with a general practitioner about this particular patient prefers this for this reason actually is quite common, and we will try and do. And as I say, that if you can, it's interesting because patients themselves now are becoming more select in coming, and I will get patients will come to me and say, they'll have their prescription, and I go, but I want this particular brand of generic.
Yes.
And actually it becomes that itself can sometimes create even more problems, because they suddenly then, oh no, we don't keep that one, we keep one persistent, and the issues around that. And interestingly, I've even had the reverse situation where I've had a patient come in, and we on occasions going back to this thing about being able to get the price of brands, on occasions you get deals which allow you to purchase brands at more competitive prices because they're off patent. And what happens is you give the person the brand, they go, no, I don't want that. Can I have one of that?
The generic,
Can I have the generic, please? I don't know. So actually, because it's really complex in terms of the way it works. And actually, I think what's key to this is the relationship that I think between general practice and pharmacy. And I suppose I am very fortunate that I've had a relationship with my practice because of the sessional work I've done with them for 20 plus years. So they know me very well, and we can have those conversations. I'll go to clinical meetings and those sorts of things. So having the opportunity to engage in that debate. But it is then the ability that the third person in that triangle is the patient. Yes. And actually being able to think about having the conversation with the patient about their issues around particular product, recognising that if you do change the generic you've given, to make sure that you've told them that they understand it is the same product, having this conversation, or
I think this patient
consistency
issue.
Sorry, Ash, had you finished?
Yeah, no, I just say the consistency, but I think what we have to bear in mind is particularly the discussion and conversation we have with the patient between all of us, to make sure that they do get confidence in the medicine that they are taking in some shape or form.
Because it's known that 30% of the effect, or whatever, is a placebo effect.
Well, and also we know, you see, some of the data around medicines is quite interesting. Not just generics, that we know that 6 to 8% of hospital admissions are related to misused medicines. 30 to 50% not taken appropriately. The way they're designed to. And these are all things which actually have an even more significant impact on the outcomes for patients.
Which gets us into
sorry,
the
let me just bring
sorry. I'm a little bit confused about this consistency of supply issue. Are we implying that it's a problem to change the brand, or are we saying, because when you prescribe generically, that's the bigger problem, because from month to month, I know Ash says that he supplies one brand, but in most cases in pharmacies, they could be getting a different brand depending on what's cheapest that month. So if we're worried about variability, then prescribing by brand, you're going to by generic, you're going to get more variability. Whereas I think that's why I quite like the category C piece about, you know, where you can prescribe a brand, because then you get the consistency. You've got the cheaper option and you've got the same brand. Yes, there may be a change once, but actually if you're prescribing by brand, that could change from month to month anyway. And I'm not sure that patients necessarily across the country get all of that support from community pharmacy when the changes are made. I think patients are sort of, particularly those on long-term multiple medicines, are used to the brands change. Certainly when I've worked in pharmacies, that's very much been accepted that the population will just adapt to that and work with a changing picture, and we've not really stopped to think about what the impact is on individual patients, particularly in specific conditions. Mental health would be a great example where there is evidence about confidence affecting treatment choice and adherence to treatment. So I think, you know, that's a key area, but it looks like on the face of it, as I said, a bit of a win-win. You make a saving on the prescribing budget, and if you do it in a managed way with the supply available, then the patient gets consistency. If it wasn't for this knock-on effect, unintended consequence on community pharmacy remuneration, it would really be a bit of a no-brainer.
Okay, so that's really interesting that you sort of summarise it like that. The big sort of, the elephant in the room is the effect on the community pharmacy contract. But how guaranteed are we that category C would always be cheaper? Is that not an issue?
I think if you work on the basis of probability, when you say category C would be cheaper, or to prescribe by brand,
yes.
Well, on the face of it, if you look at what's in there, by default the price in category C is benchmarked against the original proprietary brand. It's actually the market leader, and we've seen examples to change where a particular branded product was prescribed more, and that becomes a category C price. By and large, most of the things in there, and I gave the example of Ultra, there are others in there as well. They've all been off patent for years and years, but because of this model of benchmarking, if there is a brand prescribed, that's generally the market leader, that'll stay the same. And in fact, the only time that changes then is if an alternative brand, so if the whole country started prescribing, or large swathes of the country started prescribing one particular branded generic, then the price will drop. But that's fine. If you're the one prescribing that commonly used brand, you won't lose. You could then prescribe it generically and still be, charged the same. So there's no loss on the NHS side in terms of the price dropping, and the probability of prices, the actual category C benchmark price drop, it's almost negligible from what I've seen looking back.
And I agree around the category C bit of that, but one of the things that you do the risk you start to get to is that one of the values and benefits of generic prescribing is that there is a competitive market. And there are a number of suppliers who look at that and see the value of prescribing in that market. And as I say, we use particular ones, but there are lots of pharmacies that don't. And the reason is because the price will alter. If you switch some of these to this away from that, what you may well find is that some of those suppliers will stop manufacturing. And then the consequence becomes there is less competition availability in the market, and as a consequence, you then will drive price up. We've seen it before. It happened with category D. Which created a massive problem to the market because there was suddenly a shortage of particular products which came in. So what happened was the price rocketed because it became an opportunity in a way. And actually we have to recognise there are some risks involved in some of this, and if we're not careful, the risks can exceed the benefit. And so it is, I think we can make it very simplistic and say, yes, this is a really good thing to do, but actually you have to then think, what is the consequence, and does it have a consequence which is not necessarily for this year? You may make the saving for this year, but next year it may cost you a fortune as a consequence, and you just have to
hypothetical risk.
Yeah. It is, but we have to consider it.
Pull that back. I still very clearly feel that we should prescribe generically as much as we can. I recognise there are times when for short-term savings we may need to just step aside from that principle, and I also recognise that there are times when it is not a good idea to prescribe generically, and generics are not necessarily the holy grail, and that 80-20 split I think is about right. What we're talking about here I think is medicines optimisation, which is the new kind of buzzword for how do we support patients get the outcomes that they need. generally they accept the generic message. I think they also accept, in my experience, they also accept that when I prescribe, I'm looking at how cost effective that is, and they will accept that we have to prescribe in a way that is relatively inexpensive, or as inexpensive as we can make it. So they generally accept that. But we do cause confusion, and medicines optimization is one part of the way that we try to get around that. So that would be how we work with community pharmacy, how we work with the patient, how we maybe produce patient information leaflets along these lines, so that if we do make a switch, we're very clear and we have very simple messages that help to support that switch. But that kind of communication is going to be fundamental to this type of work. But whatever we think, I still think there is an issue with some patients who really find it very difficult to cope with this discontinuity in the way that we supply treatments, not only generic but also branded products as well.
And I think that Martin's, to expand on Martin's point around medicines optimization, I think there's a more valuable question to be asked, other than should we prescribe by brand to save money. If we change the question to, is that an opportunity to release some resource to really support patients with medicines optimization? Because I see lots of good ideas out there at the moment, business cases even going to CCG boards. And the conclusion is it's a great idea, but how are we going to pay for that initiative? And that so many fall by the wayside. I think this is a great opportunity to put a business case that says, here's a good idea. Pharmacists can really step up to the plate to help patients with their issues around medicines. And with respect, most of the bigger ones of those issues are not probably whether it's brand or generic. It's about understanding of the disease. Is it the right treatment? Concerns about side effects, real meaningful meds optimization. And we could address those by using this as a pump prime to fund that business case. So actually a business case that says that we found a way to release some savings within the business case, and rather than just banking a saving for the sake of it, we're also putting plan B alongside it, which is to drive this medicines optimization.
You're laughing.
I must be honest.
Please tell me what you think about that.
The cynic in me, as a community pharmacist, has seen that as being an opportunity, an offer since 2005 with a new contract. And actually what happened was, at the end of the day, these organisations currently are going through financial challenge. So you're not going to look at it and go, actually, let's save a bit and we can put it back into somewhere else. It's about, let's look at the saving, we'll keep that because that will help us to meet our financial targets. There are other things which are going to do that, and some of the work, and I think some of the work around actually supporting patients around urgent and emergency access to long-term people with long-term conditions ending up in A&E, and helping to understand some of that is far more valuable, and I think will create greater revenue opportunities and savings for CCGs. I think this may be a small piece of that and may help in some ways, but the cynic in me says this will not get reinvested.
Well, sorry, let's Shailen come out first, please, because he was trying to get
Well, I think that's the whole, you're putting the business case on the basis that you do the two together, and if the decision-making body, the CCG board, says no, then I think it's fair that community pharmacists take their bat and ball away.
Okay.
Because I think the kind of initiative that Ash is describing is exactly the type of thing I'm getting to. But the problem with that is you put that to a board and they say we love it, but where are we going to fund it from?
They have to be
so you need the two to work together. And that's exactly it. And I think that there is a difference from 10 years ago when the pharmacy contract came out. And if you look at the wider the pressure, the financial pressure, and this whole drive to transformational change rather than transactional change, every profession, every provider is having to work differently under this banner of doing more with less, quite frankly. And I think this is a practical example of that, with pharmacy being engaged. And the initiatives I'm talking about that could be run are not necessarily just quality initiatives. They're the things that are going to save much more money, potentially. But we have to find a way of pump priming them. And right now, additional investment in very good ideas that could save money is still hard to get support for.
I can see both sides of that argument, and I find that actually quite a persuasive argument. I do think I agree with Ash that the problem is that we're just so busy scrabbling around trying to deal with our overspend that it's very, very difficult to look at things in the concept of invest to save, which is what we're talking about.
Absolutely.
But at the same time, I think that the way our demography is changing with this overwhelming surge of older people with multimorbidity coming along, we really do have to transform the way we provide services. And a lot of that efficiency is around medicines optimization and how we encourage people to take 10 or more medicines, which is commonplace now, and we support them to do that. And we ensure that we don't give them unnecessary treatments and all those kinds of issues, or that they're not expected to continue to get prescriptions for things that they don't really want. All those kinds of things need to be sorted out. So I think there is a real opportunity to say this is a transformation that we need to go through. And this issue about making sure that people get the best out of their medicines is just crucial. Otherwise, we're just wasting our drug budget.
Absolutely.
No,
So,
I think you're obviously absolutely right. The whole prescribing issue and what the value for money we get from what we spend on drugs is something we need to look at. I just want to suggest something which you may or may not think is a good idea. So if everything were always written generically by the doctor, and the pharmacist was allowed to make the decision as to which was the most cost-effective drug to dispense, including whether or not for the patient they should be giving the branded, the category C or the category M, taking into account the patient's need for continuity of product. Would that be something that we would be supporting?
Well, you saw the cynic in Ash, I guess the cynic in me now, which is that actually will the pharmacists across the country, present company excluded, whose interest will the decision be made in? There are businesses and there will be will it be made in the NHS or patient interest? I would like to think so, but naturally, there is going to be an issue about making the decision. I mean, in a sense, right now, with some of the branded generics, category C, people could choose to prescribe and dispense. The choice is open, but by and large, the more expensive alternative is what gets endorsed, as far as I can see.
And with the current system, there's confusion.
Well, and you can't blame individual pharmacists. I mean, if we create a contractual mechanism that rewards people in a certain way, that's what we have to address. And actually, the community pharmacy model is still very heavily focused on supply, and we get a great deal for that. But then we can't expect great quality and service provision off the back of that until we change.
Ash, could you trust your colleagues not to be have a conflict of interest there?
I think you're always going to find people who will see it as an opportunity. It doesn't matter what you do, in whatever shape or form. If you try to drive costs out of the system, you'll get the reverse as well. It's the way of the world. At the end of the day, it's what you will always get a small percentage of people. What we have to look at is what will the vast majority do. And I think these days there is much more sense of belief in the value and the return for the patient than I think we've historically seen. I think some of the things that have happened are starting to change that respect. However, as long as you have a contract which is transactional completely in the way it operates, in the way that Shailen has described, you will create more opportunity for that to happen. So what you have to think about is, what does that framework look like? How do you change it? Which says, actually, the medicine bit of this is part of the care package. It's not the sole bit of it. And actually, that's the way you get it to work more efficiently, because it's the whole care package. And that's the bit about how we work more closely with general practice and with patients. So actually, it is in the best interest of the patients, it's the best interest of the health service, because actually at the end of the day, I'm also a taxpayer. So I fund part of the NHS, so it's my money. So why am I going to try and, so it's a sort of...
I'll bring you back in a minute,
sure.
but how would the GP feel about trusting the pharmacist to make the right decision?
I think at the moment the difficulty I have is because we have, as I've said, we have quite a few community pharmacies that we work with, and it's very difficult for us to... each pharmacy is different, and they seem to have a different relationship with our patients as well, which is quite complex. So I think if we're looking at it in a kind of revolutionary format, which is the transformational argument, then maybe we all prescribe generically. Maybe patients get registered with a pharmacist and would have to deregister if they want to go to another pharmacy. And then you develop that type of relationship where you maintain that continuity of care and support for medicines taken and medicines optimization, as I keep going on about. and those types of things become a reality. That is a big change in the way that we work.
It is and it isn't, because at the same time, just around that, is that although we don't have registration, I do think there are some values in registration in a number of ways that I think would benefit the system. Lots of patients do effectively nominate their pharmacy. So they tend to go back if they're on regular long-term medication. They do tend to be quite consistent because they like the pharmacist, or they like the pharmacy, or they like the speed it's done at. There will be something, as you say, it's a complex relationship, but there will be some reason that they will tend to go fairly regularly back to them. It tends to be for more acute conditions that people will be much more variable in what they'll use, because it's about and it will be entirely about convenience. But even with the long-term condition, the one they will use regularly was because it'll have a convenience factor as well in it. So I think there is a certain amount of continuous use of particular pharmacies, and actually we need to recognise that is the case, and as we get more and more long-term condition patients, that we're going to get more and more of that happening anyway. And with electronic prescribing, electronic prescription systems, patients do effectively nominate their pharmacy, so the GP gets to know fairly quickly, because effectively the script goes automatically to the pharmacy if they have nominated. So you start to be able to identify which pharmacies particular patients are going to. You can start to look at whether you've got particular issues around the way that's working, and then be able to have those conversations with those pharmacies about those cohorts of patients in some ways. So I think there is more and more opportunity to start to make this happen. We just have to recognise how we make and do it as part of what we're trying to achieve.
So has the cynic in you been
reassured?
Well,
I think we need to really transform the way the contracts work, and I think this is a microcosm of the bigger issue in the NHS, and I think the same would apply to GP contracts, etc. And I think there's a real opportunity here. And actually interesting, listening to my colleagues here makes me realise pharmacies are maybe a great place to do it because they're not that far away. So the opportunity here is to contract in a different way. And at the moment, and I think going forward, what we're going to see more and more of is outcomes-based commissioning. Community pharmacy at the moment is very transactional, input-based, activity-based contracting, and we're trying to get away from that. And having this concept of a list, a patient belongs, and they've now got a formalised arrangement with the pharmacy owning its list size, which it sort of does anyway, as Ash has said, but it would really free up the community pharmacists to add value in things that really make a difference. And I think for me that in itself is moving from transactional to transformational. And in my mind it conjures up a great Albert Einstein quote, which is, to solve problems we have to use a different level of thinking than those that created it. And I think that sums it up really with the pharmacy contract. I think anything else, we're going to be tinkering at the edges of something.
I agree with that. I think it also applies to the general practice contract. I think that the system that we have is not really fit for purpose, and we really do have to revisit it. And I think many GPs are now recognising that that's the case.
It's not helping
it is similar. It's been set up on a transactional basis. That it's based on how much money that comes into the practice in effect, and what we're being asked to do is really in excess of those resources at this point in time. So that's another issue. So alongside that, though, I do think you have to reform the way that drug costs are reimbursed. I think the way that category C, category M, and other issues related to reimbursement need to be revisited, and that would enable this change, this transformation.
So I'm sorry, I think we're sort of beginning to run out of time. I'd like to ask you all one final question. I think we've moved now to looking to the brave new world and actually getting a very good solution that maybe one day will happen. But in the short term, we're left with the current system. So a final question for you, just a quick answer please. With the current system, what would you be suggesting CCG should be recommending to ensure both financial probity and quality of care with respect to generic prescribing? Yes, I'll go to you first, Martin, as the prescriber, and I'll go to Ash, so and then if you're going to have the final word, Shailen.
So really I'll be reiterating the way that I've been saying things earlier, which is that I do think generic prescribing is the right way to go for most products. I do think that we need to be clear that you can over-prescribe generically, and therefore there are certain things that should not be prescribed generically within the current system, and we need to be really clear and have a list of what those things are. I do think we need to recognise that there are certain instances where prescribing by brand actually saves us money, and again I think we need if you like, a stable list of the items where we are intent on using that in order to help us with our savings within our health economy. Ideally we would wish to reinvest those savings in medicines optimisation and working better with community pharmacy, but at this point in time, with our current financial restraints, unfortunately I don't think that's particularly realistic.
Okay, thank you. Ash?
I think we have to be careful that what we don't see is short-term gain and long-term consequence, so we need to be really clear about doing it. I absolutely think we should maintain the principle of generic prescribing as being the right direction, and that we see the value in prescribing generically in the right conditions, and maintaining the availability of product effectively by continuing to prescribe generically rather than branded generic. I think there are occasions when you prescribe unbranded generic, but you have to have assurances about the long-term sustainability of the financial model that's created as a consequence, and that isn't going to have a consequence that you haven't realised the way you do it. So, but there may be times when it makes sense. Overall, as we progress, though, it's interesting because if we get to what we described, this becomes less and less of an issue, because actually the relevance of the generic within that package becomes part of the care. And I think what we need to look at as we move forward is think about what we are trying to create in terms of quality of care for patients, and then making a decision about whether it's generic or branded or whatever else, whatever other form it is. So that for the patient we have an assurance, and it gives us the opportunity to optimise their use of that medicine.
So the patient is central to the decision.
Absolutely.
And Shailen, what will you be advising your CCGs?
Very much in line with what the other two have said. Yeah, if the patient really is at the centre of this, let's use this as an opportunity to drive something bigger and better, because I think it's a very valid point. We have to work within the current constraints, and those constraints are only going to get tougher. So I think, prescribe generically as a rule. There are a few exceptions, and where those gains are sizable, manage them effectively, pick your battles carefully. But the real juice in this is about utilising what comes out of it to do something bigger with it, and I think there is an opportunity to do that, and that can take, be very good for pharmacists, for GPs, but also as a result, it's almost by default then good for patients as a result, because we can really focus on things that matter.
Okay, so I think that's an excellent point to end. I think we've almost all come to an agreement. So
maybe the first and last time today.
Thank you very much for your interesting contribution and
Thank you.
for taking part in this debate. Thank you.
Thank you.